Welcome to this video on venous thromboembolism. We will explore this condition through a single patient case, linking the diagnoses of deep vein thrombosis and pulmonary embolism from the calf to the lung. This walkthrough provides essential information for residents at all levels, from junior to senior. Let's meet our patient. A 62-year-old woman, 5 days post-op from a right total knee replacement, presents with calf pain and swelling. Shortly after arrival, she develops pleuritic chest pain and breathlessness. Her vitals show tachycardia and a drop in oxygen saturation to 93% on room air. In this video, we will define VTE, explain Virchow's triad, and identify key risk factors. We will also learn how to apply the modified Wells score for both DVT and pulmonary embolism, which are vital tools for guiding our diagnostic approach and deciding when further imaging is necessary. Continuing with our objectives, we will cover the physical exam and imaging findings for PE, as well as the use of age-adjusted D-dimers. We'll discuss risk stratification, management of special populations like those with HIT or cancer, and the indications for interventions like thrombolysis or IVC filters. Tracking our patient's timeline is essential. Following her surgery 5 days ago, her calf symptoms began 2 days ago, and she developed acute respiratory symptoms just 1 hour ago. This sequence illustrates the classic path of a leg clot breaking off and causing a pulmonary embolism. Our patient's history reveals several stacked risk factors: obesity, recent orthopedic surgery, immobility, a long car ride, and a family history of VTE. Importantly, she stopped her postoperative clot prophylaxis on day 2, leaving her vulnerable to the development of this thrombus. The physical examination shows classic signs of DVT in the right leg, including significant swelling, warmth, and tenderness along the deep venous system. Her cardiopulmonary exam, with tachypnea and a loud pulmonic component of S2, strongly suggests the clot has migrated to her lungs. Let's be precise with our definitions. VTE is the umbrella term for DVT and PE. Proximal DVT, occurring in the iliac, femoral, or popliteal veins, is significantly more dangerous than distal calf DVT due to a higher risk of embolization and mortality. The clinical significance of VTE cannot be overstated. It is common, frequently silent, and highly lethal if missed. Because up to 50% of symptomatic DVT patients have silent pulmonary emboli, a structured, probability-driven approach is vital for patient safety. Virchow's triad describes the 3 forces that lead to thrombus formation: stasis, endothelial injury, and hypercoagulability. Our patient demonstrates all 3, making her development of a blood clot a highly predictable yet preventable event. The pathway from leg to lung starts with clot nucleation in the veins, followed by propagation, embolization, and finally, lodging in the pulmonary arteries. This obstruction creates dead space ventilation and right ventricular strain, which is the primary factor we use to assess the risk level of the PE. Understanding risk factors is crucial. We categorize VTE as either provoked or unprovoked. Our patient's condition is clearly provoked by her recent surgery. This distinction is vital, as it guides our management plan, including the duration of anticoagulation therapy. Effective thromboprophylaxis is matched to the specific patient and situation. Orthopedic surgeries, such as hip or knee replacements, require extended pharmacological prophylaxis. Failing to continue this, as happened with our patient, significantly increases the risk of preventable clot formation. Clinically, DVT presents with various signs, but none are diagnostic on their own. Because symptoms are often nonspecific and can be mimicked by conditions like a Baker's cyst, we rely on the modified Wells score to objectively calculate pretest probability and decide our next clinical steps. Finally, here is the modified Wells score for DVT. We assign points for factors like active cancer, immobilization, surgery, and specific physical findings. Importantly, we subtract 2 points if an alternative diagnosis seems just as likely, ensuring our clinical suspicion remains accurate and focused. Now, let's total the points for the modified Wells DVT score. A score of 0 or less is low probability, about 5%. A score of 1 or 2 is moderate, about 17%. And a score of 3 or more is high, roughly 53%. Let's score our patient. She receives 1 point each for recent surgery, tenderness, swelling, calf measurement, and pitting edema. That totals 5 points, placing her in the high probability band. A caveat: this score is most useful for outpatients and less reliable in hospitalized patients, where we move straight toward imaging. This algorithm shows the diagnostic path: For low or moderate probability, we send a D-dimer. Values under 500 effectively exclude a clot. If the value is 500 or higher, we perform a compression ultrasound. For high probability patients, we bypass the D-dimer and go directly to imaging. Compression ultrasound is over 95% sensitive and specific for symptomatic DVT. A positive result confirms the diagnosis, while a negative result excludes it. Follow the logic of the algorithm, and the workup for your patient becomes clear and systematic. Now, we turn to the chest. Common symptoms of a pulmonary embolism include dyspnea in about half of patients and pleuritic chest pain in 40%. Less common signs include cough and hemoptysis. Physical findings may reveal crackles, tachypnea, and tachycardia. Warning signs of a massive PE indicating acute right heart strain include syncope, hypotension, P, raised JVP, a right-sided S3, a loud P2, and a murmur of pulmonic regurgitation. Our patient shows dyspnea, pleuritic pain, and tachycardia, which warrant urgent investigation for PE. The modified Wells score for PE uses weighted values. Signs of DVT and a less likely alternative diagnosis are worth 3 points each. Heart rate over 100, surgery, and prior VTE are 1.5 points each. Hemoptysis and active cancer add 1 point each. Our patient scores 6, marking her as, quote, likely. In the simplified Wells interpretation, a score of 4 or less is considered unlikely. A negative D-dimer here safely excludes PE, saving the patient from unnecessary radiation. However, our patient's score of 6 means she is likely, so she requires a CT pulmonary angiogram regardless of D-dimer results. Before the CT scan, bedside tests provide clues. A chest X-ray is often normal, but may show a Hampton hump or Westermarck sign. An ECG might show sinus tachycardia or S1Q3T3. ABGs often show hypoxemia and respiratory alkalosis. Remember, age-adjusted D-dimer cutoffs are critical for older patients. The approach for suspected PE is similar. If unlikely, check D-dimer. If likely, proceed straight to CT pulmonary angiography. While CTA is highly sensitive and specific, clinical judgment remains paramount. If scan findings and clinical suspicion disagree, consider further diagnostic testing. After confirming a PE, we must grade its severity to determine our management. Hemodynamically unstable patients with arrest or obstructive shock are high risk or massive. Hemodynamically stable patients are stratified into intermediate or low risk based on SPESI, troponin levels, and right ventricular function. Management depends on the lesion. Superficial thrombosis is usually managed with support, while proximal DVT and PE require anticoagulation. High-risk PE requires aggressive reperfusion therapy. Our patient is currently stable, but requires careful monitoring of her troponin and RV function to assess for intermediate risk status. Choosing an anticoagulant is key. LMWH is preferred, especially in cancer or pregnancy. Unfractionated heparin is indicated for unstable patients or those needing thrombolysis. DOACs allow for outpatient care but are contraindicated in unstable patients. Always screen for HIT if starting heparin-based therapy. For high-risk PE, systemic thrombolysis reduces death and recurrence, but increases bleeding risk. Catheter-based suction thrombectomy or low-dose lysis are options for intermediate or high-risk cases where systemic lysis is contraindicated. IVC filters should only be used if anticoagulation is absolutely contraindicated. Duration of therapy varies. Superficial clots need 4 weeks, while distal DVT needs about 3 months. Our patient requires 3 to 6 months for her provoked clot. Extended therapy, particularly with half-dose DOACs, should be discussed for unprovoked cases, balancing recurrence reduction against bleeding risks. This video is supported by clinical resources from the American College of Chest Physicians, the European Society of Cardiology, and the American Society of Hematology. Content regarding risk scoring and management draws on established literature, including Wells' original work and various randomized trials on anticoagulation strategies. We will continue exploring this case in the next lesson, where we focus on the workup of unprovoked clots and long-term anticoagulation strategies. You can find the link in the description or click the thumbnail on your screen. Thanks for watching, and I look forward to seeing you in the next video.